welcome all. My name is Jinwan Jema. Lovely to have everybody once again for our monthly emergency care talks. So excited to be joined today by Dr. Evans. We are going to be talking about transport of the critically ill patient, and there's no one better to talk to us about it. Dr. Evans is an emergency medicine trained doctor with qualifications from the College of Medicine of South Africa, and he's also a member of the Royal College of Emergency Medicine. So we're really, really excited to gain some information because we always see critically ill patients in our units. And depending on what facilities we have, we can either transport them to a critical care unit within our hospital or transfer them out. So we need to learn how to properly do this so that the patient actually makes it to the other side. So karibu, Daktari. Excited to learn from you.
Thank you, Dr. Wanjema, for the kind introduction. So we're going to talk today about the critically ill patient. And just a minute. So I believe we all have, as a doctor, we've all encountered a critically ill patient at one point or another. And ideally, patient is in their best condition in setups like the ICU. They're not being moved, they're connected to all these ventilators. They're constantly being monitored. They have infusion pumps and everything. It's a very controlled environment. But occasionally we do need to move these patients for whichever reason, out of this comfort zone, so to speak, out of this safe space, to either another facility or to within the same hospital. And that's what we're going to be considering. Well, it's not anything new per se. I think the person who's considered the father sort of transfer medicine is this gentleman who was the surgeon-in-chief for Napoleon Bonaparte. And during the war, he'd be transporting soldiers in and out of the war zone. And well, this is what we'd call the primordium, the ambulance. You can see just how rudimentary it was. But we've come a long way from this. Now we have planes flying people around and so on. So essentially, transport of critically ill patients can be classified into three. It can be primary transport. This is commonly done maybe by EMTs and other ambulance crew, and can loosely call it CASEVAC. Essentially, this is, you've had an accident at some place, and there are people responding, and some of those patients are actually critically ill. And so traditionally it's been, or rather how people have gone about it, it's in what's called the scoop and run kind of model. Just pick the patient and rush them to the nearest facility, because more often than not, the first responders will probably not be equipped adequately to respond to all the needs of this patient. So this patient needs to get to hospital as soon as possible. And there can also be what's called secondary transport, where you have a patient who's admitted at a particular hospital, and now they're being transferred to another hospital. And usually it's a higher level of care. For instance, someone has had an accident. I'll probably keep using accidents quite often, just bear with me. But has had an accident in some corner of Kenya, and now they have to be transferred, to Nairobi, a hospital in Nairobi, so they can get the care that they actually need. But a patient wants to be repatriated home to probably be close to their family, and so on. But you also have something that we commonly do that almost every doctor will get to do at some point in their career, which is intra-hospital transfers. So it can be from one department to another, and this is done daily and multiple times a day. So transports, well, can be largely looked at from two perspectives. One is, can either be ground transport versus air transport. Of course, when it's intra-hospital, then this doesn't apply. This is mainly for primary and secondary kind of transport. And what you choose then will depend on where you're located. I mean, some remote location where there are no roads, or you need to get across the sea or some water body, and you will probably need airborne transport and so on. How urgently do you need to transfer this patient? Is whatever the ideal form of transportation available in your area? What are the environmental weather factors? For instance, if there's a storm, or if it's a cloudy day with really bad weather, you probably don't want to consider flying, as opposed to ground transport, and so on. The patient factors as well. How stable is this patient? Able to tolerate one form of transport versus the other? So, as has been alluded to, we transfer patients when they are. So either we lack in terms of staffing, in terms of equipment, or in terms of the diagnostic facilities that the patient requires. It must be deemed by the transferring team at the risks of transporting this patient, because transporting a patient is not without risk. The risks at the point of transfer outweigh the potential benefits that will be accrued from the patient being transferred to the destination. And ideally, we want to transfer a patient to a facility of a higher level of care. So again, transfers are, there's quite a bit of morbidity associated with just moving the patient from that comfort zone that we started by describing. And I haven't seen a lot of data from the African setup, but in Europe, there's this audit done in the Netherlands where they report up to 34% incidence of adverse events during transfers. And it's important to note that a majority of this were actually preventable adverse events. And they were attributed to several factors, but the core factors were equipment failure, inadequate preparation. And I have to put emphasis on that because your success or failure really is pegged and depends a whole lot on how well you plan for transfer. Also poor communication and documentation. For intra-hospital transfers, depending on, there's been several evidence, but essentially the range is from about 6% to 71% adverse rates. So essentially during transfer, we want to maintain the patient, or to at least try and approximate or approach the standard of care that they have been accustomed to, or the referring facility as much as possible. And to try and shorten that duration, that will then again have a bearing on the incidence of adverse events, to shorten the duration of transfers as much as possible. But the key message during transfer is, and in medicine really, it's safety. Safety for the patient, not just for the patient, but also for the staff that are transferring the patient is very, very key. And we're going to see, see this even as we discuss further, why a speeding ambulance is probably not the best idea for a patient and all. What could possibly go wrong? And in this section, we're just going to discuss what the two key modes of transportation or transfer that we would do for a patient, which is by road or by air. So this is the pictures below here, just a cartoon of an ambulance with a patient lying inside. And in this first picture, the ambulance is accelerating that way. Now, according to Newton's laws of motion, there's an inertial force that's acting in the opposite direction on everything inside the vehicle, including the patient. On the other hand, we have an ambulance that's decelerating from very high speeds. I've had an ambulance driver say they were driving at 200 kph. So from assuming this is at 200 kph here, now we have to stop. So we are decelerating. And the patient, the inertial force on the patient is pushing them that way. This has physiologic effects on this patient lying in there. And we're going to just look at some of the effects on the physiology of this patient. So in the cardiovascular system, when you have car accelerating that way. And it's important to note that the deceleration force of ambulances is greater than how much force it takes to accelerate them. So actually the inertial force working on the patient when you're decelerating the ambulance, for instance, is a lot greater than that when you're accelerating it. Anyway, this inertial force will act on anything that's movable within the body, be it the blood or the viscera, and move them in the line of the inertial force. So in the cardiovascular system, this means then you have blood pooling, assuming that the patient's head is towards the driver's side, and you have blood pooling in the lower limbs. And that means reduced venous return to the right side of the heart. And for critically ill patients, a lot of times their baroreceptor reflex will be blunted. So this can result in hypotension. You might notice that your pressure requirements are going up. But also, if this patient is intubated or they are in any kind of positive pressure, or they're hypovolemic, then you accentuate the hypotension even more. Now, for a patient who has a head injury, for instance, and cerebral perfusion is not too great because the intracranial pressures are high, and because of the speeds or the deceleration acceleration forces, you're shunting blood towards the lower limb, then you might impair cerebral perfusion. Again, when it comes to deceleration, then the opposite happens. You have more blood being taken towards the head side, just in the line of the inertial force, as we saw in the earlier picture. So in a patient whose heart is struggling to pump, then you might just very well tip them into pulmonary edema or arrhythmias, or they may just make their heart to fail more. But in a patient who has a head injury again, and you're trying to, well, can result in a lot of, increased ICP. For the GI, like I said, viscera are also quite mobile within the body. And so you can have cephalad displacement of the stomach and other viscera. And this can compress the diaphragm, increase the intrathoracic pressure, again, interfere with your ventilation. But the displacement of the stomach can also result in aspiration in these patients. Now, for patients of spinal injury, you can have just that deceleration force then causing some axial load to the spine, which can result in displacement of unstable. So ideally, it might seem like taking off at 200 kph is the best idea for the patient, but maybe not. But also for the staff and other occupants of the ambulance. And we've seen ambulances get into accidents and that sort of thing during transfer. It's also important to be wary of these acceleration, deceleration forces that could occur during transfer. But there are also hazards are not inherent really to the movement of the ambulance. For instance, noise. This particularly would happen in aviation or in aeromedicine. So of course, this will interfere with communication. It can cause quite a bit of distress, not just for the patient, but for the staff working there. A lot of our ambulances will probably not have the best temperature regulation. This can predispose to hypothermia for the patient. But sometimes you have to evacuate a patient over long duration. Sometimes they're lying on a spine board, that's or whatever structure you use to get them into the ambulance. And that can predispose them to pressure areas. Also, just lying in that supine position over prolonged durations and can cause some pooling of their blood and body fluids in the dependent areas. And this can, again, contribute to the pressure source. It's generally advised that you don't have extrication boards or hard surfaces next to the patient, especially when you have to prolong the transfer. If you're in a fancy setup where you can afford a vacuum mattress, then that would be a good idea to have. So during air transfer for critically ill patients, then there are again some things to be wary about. One, as you go higher, well, there's the old adage, as you're growing up, the higher you go, the cooler it becomes. Also, the higher you go, the less oxygen tension you have. So as you go up, your atmospheric pressure drops. Also, your partial pressure of oxygen decreases. So you can result in lower oxygen tension in the alveoli, which can essentially predispose you to hypoxia. So you can mitigate for this by increasing your FiO2 or pressurize the cabin. If it's a pressurized aircraft, then pressurize the cabin to a lower altitude. The last one is most commonly not feasible, which is reducing the altitude of the flight. Sometimes you can do that, sometimes you cannot, or because of various factors which are really in the aviation industry. We'll not go in so much into that. But again, what happens as you go up, we've said that generally as you ascend, as would happen during air transfer, then your pressures, the atmospheric pressures are reducing because the column of air above you is getting thinner and thinner. So as your pressure reduces, I don't know if you can see my cursor, but as your pressure reduces, as it tends towards zero, then you'll notice that your volume also increases. So this is what's called Boyle's law. And this would be applicable if you're transferring a patient, for instance, who's suspected to have an pneumothorax, or a patient who's suspected to have an intestinal obstruction. Essentially, a patient who has air trapped within a viscous or an enclosed space. Because as you go up, that air will obey Boyle's law. And that means that it will expand with time, and so worsen your symptoms. So you probably want to do things to mitigate for this way before you transfer this patient. That same applies for air in any enclosed cavity, including the cranium, so pneumocephalus, pneumoperitoneum, or when you have to deal with equipment that have air-filled cuffs or bags. Key amongst them is an tracheal tube. Again, I began by this section by mentioning that the higher you go, the cooler it becomes. So your temperatures actually drop with ascent, and depending on what mode of transfer you're using, then the patient might be predisposed to hypothermia during air transfer. But then again, your ambient humidity at higher altitude is lower. So this can predispose you to more evaporation from your or rather more insensible losses through your lungs, through your skin. So patient is at risk of dehydration. So it's important to note this, especially for patients who are hemodynamically unstable. You might need to keep monitoring how much input and output they're making. But also it's important to beware of the patient, just because of this dehydration and drying out the mucous membranes, that the patients then can have thickened secretions, which can predispose to mucus plugging. So if you have an ETT in place, then this is a patient who could very well, stop ventilating as well as they ideally should. And there are ways to mitigate for that, including a HME filter and using humidified oxygen. Again, we forget the eyes, such small things, but very critical, because if the eyes are constantly exposed and tear production is not too great in this patient, then you can get that keratitis over time. So it's good to lubricate the patient's eyes over long distances, because again, the ambient humidity will be low. Again, during air transfer, you're still susceptible to acceleration, deceleration forces, and what's called G forces, which are a similar concept, except this time it's with gravity. And as well as noise and vibration. I'm sure those of you who've been on medical evacuations can attest to this. And this can worsen delirium in a patient who's already delirious, or even trigger delirium. Also, just generally agitate patients. But also, you can be quite a bit of vibration and turbulence with aircraft, which can predispose to fatigue, equipment malfunction, again, can predispose to MSs and so on. But it's also important to consider that air transfers usually occur in a very limited space. So if you have to transfer a patient, then you need to have done most of the things that you need to do beforehand. So this is a rather busy slide, and I apologize for that. But essentially, it summarizes ways in which you can mitigate for the various physiological hazards and the various problems that we've been looking at. So I've kept mentioning that the patient should be stabilized prior to the transfer. because you anticipate that they might have these physiological disturbances. But again, if you tilt it's been found that if you tilt the head of the patient just above 15 degrees, this might then mitigate for the effect of the inertial forces that we've discussed on ICP. Again, to counter the effects of acceleration, where we said there's venous pulling towards the leg sides or towards the lower extremity of the patient, then one of the things you can do is just raise the patient's legs. Instead of rushing to dial up the vasopressor dose, you can just raise the patient's legs, and that might actually help bring the blood pressures back up. Again, for patients who are intubated, then you need to be wary of the risk that they might have emesis. Again, we mentioned those acceleration, deceleration forces, and the fact that the stomach can sometimes, because of deceleration, can be pushed cephalad and can predispose to aspiration, and just have an NGT in place, just in case that happens. But temperature monitoring, pressure area care, those are important things to look at. Now, again, for patients who are going by air transport, some of the things that you can do to mitigate against some of the physiological hazards, we've looked at if it's a patient with a pneumothorax or suspected might develop a pneumothorax, then one of the things you can do is actually, try and put in a chest tube beforehand. Again, because of the effects of hypoxia, giving supplemental oxygen in flight would be helpful. And then I'll insist on this. It's good to do everything you can before transport and not be doing things within the transport, because a lot of times the conditions are not conducive. Also for the air transport, because you can't park somewhere and intubate a patient en route. You need to have done that on land if you needed to. Monitoring is best done, especially for blood pressures, because the non-invasive cuffs are usually susceptible to vibration and movements. Then if it's a patient who requires close monitoring, for instance, a patient who's on vasopressors, then you're probably required to have invasive monitoring before you live with the patient. Now, there are other hazards to consider, which include a very common equipment failure. It can be disconnected, it can be the equipment, the battery life has run out. It can be that you had an IV excess, now you don't, and it's a difficult one. It can be that the patient en route extubated on you, or you actually did run out of oxygen. Now, some of them might not be things you can preempt, for instance, accidental extubation, but you can minimize the risk considerably by close patient monitoring, being very meticulous in the transfer process. Now, oxygen supply, it's always a good idea to actually calculate how much oxygen you would require for a transfer and have backup to that, not just for oxygen, but for the equipment that you require. We'll be seeing that in the next session on how to mitigate for these hazards. So first, before you transfer a patient, maybe some of the questions that you want to be should be running through your head are, does the patient require transfer? And we looked at some of the reasons why a patient would require transfer. Would the transfer then confer benefit to the patient? What would be the best way to transfer the patient, the best mode, the best route? And who should transfer the patient? Should they just go with an EMT? Should they just go with the nurse? Should they require a doctor as well? Should they require two doctors? Those are questions we should consider. Right at the onset, you've been called for this evacuation, and so these are some of the things you need to be thinking about. But what equipment, and is it working? And it helps those who are in the evacuation business to understand that there's need for daily checks, routine checks for just assess or to make sure that our equipment are ready when they're needed. Because a lot of times you don't have the time to start checking that things are working when you're supposed to go and evacuate a patient. We mentioned this, who should accompany the patient, but also just trying to anticipate what problems could possibly go wrong during the transfer. That's a skill that's probably acquired over time. It's good to imagine the worst case scenario. Personally, when I have to transfer a patient intra-hospital, that's what I've done most of the time, or a lot of times. And sometimes this is controversial, but I request for a vial of adrenaline, 1 milligram. And a lot of times people are like, the patient is hemodynamically stable, and so many other excuses. But it's just considering the worst case scenario. What if for some reason this patient arrested on you on the way? What if, just consider the worst case scenario and work from there. What other hazards might occur during transport? And just try and anticipate and mitigate them right from the start. And that way you're not caught off guard. But it's important to, put down a plan with various steps and backup steps right beforehand. Right beforehand. Then the last question, or maybe not the last question, there could be more questions, but what's also important is where I'm transferring the patient to, be it another department or be it another hospital, are they aware that we are coming? Are they aware of the status of the patient? Because a lot of times we forget to communicate. So you get to a hospital and no one is expecting you, and there's a delay in transferring the patients. Sometimes you lose patients right outside the hospital door. So it's important. Communication is really, really key in the transfer process. So again, before you transfer this patient, get informed consent. If it's possible to talk to the patient, then get consent from them. But when it's not, then get consent from the next of kin when available. But it's important, and you can't emphasize this enough, that you need to transfer a stable patient where possible. Of course, this doesn't apply if you're in the bush somewhere and you don't have all the facilities you need. You might just have to scoop the patient and run. But so I was saying, if there's any remote possibility that this patient might require ventilatory support, then intubate them before leaving. Put them on the ventilator and just make sure they're stable on that. Sometimes you do require to, if a patient is ventilated, then they'll require sedation. But sometimes you might actually require to paralyze a patient and take over their physiology completely for their transfer. Again, it's important to ensure that you have adequate venous access. The same things to make sure that all your lines and tubes that are required are placed and secured. If it's a patient you're transferring via air, we've talked about Boyle's law and the fact that the air will likely expand with altitude. So the practice is, if you can measure the cuff pressures, then measure them as you go up and deflate as needed. Of course, a lot of times we will probably not have the capability to do that. The alternative is to actually inflate the cuff of this expansion. And again, before you leave, we cannot emphasize enough, contact the receiving hospital and confirm that the patient is actually being expected by that hospital. And just prior to dispatch, just do a quick head-to-toe examination. So during the transfer, the underlying principle should be that you should maintain the patient at, or rather the level of care should approach that expected in the hospital setting to the best of your capabilities. Of course, sometimes this is not possible, but you do everything you can to just try and get the patient to where they were when you picked them. Monitoring should go on. Of course, monitoring all the parameters, you know them. But like I mentioned, invasive blood pressure monitoring is preferable because it's less susceptible to that movement artifact. Now, we've kept mentioning that speed is not the, I mean, we see ambulances speeding through the streets all the time. But actually, what's recommended is if you've stabilized your patient, then you don't need to run. You don't need to speed with the patient through the streets and expose them to all those hazards that you've spoken about. Just a slow and smooth journey to your destination might be preferable. It's even safer for not just the patient, but for the crew inside the ambulance. This might not be the case all the time because sometimes you don't have the capabilities within the ambulance and the patient is unstable and you need to get them to a facility where the care that they need is offered. If you're on a vehicle and say a patient extubates, then rather than try to intubate them unsuccessfully while the vehicle is moving, you can actually stop, stabilize the patient again, and move. Now, after the transfer, this is something that we probably do quite well, which is hand over to the team on the other side. But the handover should include written documentation of the events intra-transfer, as well as debrief with the team and possibly follow up the patient where you can. So we're bringing to a close of our talk today. And essentially, the summary of the talk is a good transfer of a patient will rely heavily on coordination, communication, which essentially falls under the umbrella of planning. Your equipment will need to be the right equipment, well functioning, the right size. There are several variables to consider, the appropriate ones for the patients and so on. But also the personnel that need to evacuate this patient needs to be the right personnel, adequately skilled to handle a critical care patient. Ideally, a team that's well-trained to handle an airway, but also a team that's well-trained to handle a critical care patient. But it's a patient who will require monitoring in all aspects of their physiology. So essentially, the message, the take-home message is that planning is really the bedrock of a successful transfer, anticipating all kinds of outcomes and scenarios, and doing your best then to avoid the less than ideal ones. Thank you for your time. I'll invite any questions or comments or additions, especially the additions. Be happy to hear what other people and the experience that other people have in transferring patients. Thank you.
I'm seeing some applause from the participants. Thank you for taking your time to go through this lecture with us. It's very, very important. We always deal with critically ill patients as emergency care providers, whether you're in the county hospital, sub-counties, or larger referral facilities. You'll either be on one end of the spectrum, either you're sending or you're receiving. So it's very important to know, like you said, to prepare for what could happen. Yeah, so just to reiterate, always prepare for the next eventuality, stabilize your patient before they leave your facility. I know when I was a young intern, I'd always jump to refer a patient, but my seniors taught me, make sure your patient can make it to the other side, yeah? So that's the most important thing. We need to make sure your patient is stable enough before they leave your hands, because they need to make it to the other side. Another important thing that I thought I can mention, if your patient is on oxygen, you need to at least calculate how much oxygen you might need for the whole trip. So so you should always calculate how much expect to use. So if your patient is like on 15 liters per minute and your drive is like an hour, so you multiply that and have at least twice as much oxygen cylinder so that your patient can make it to the other side. So it's also the same as also in transports within the hospital. from one unit to another, make sure you have adequate amount of oxygen. You don't want your oxygen to run out in the middle of your transit. Yeah, and hypoxia is a very important one of your H's and T's. Okay. So now I will go into some of the questions that we have. So I think one of the things you mentioned was patients with spinal injury. So there's a question in the Q&A that says, what are those spinal injuries? How best can you handle them when referring? Okay. So maybe you can just repeat how you had said.
Okay, so well, unfortunately, for this presentation is there was quite a huge scope. There's nitty-gritties to transferring each kind of patient, for spinal injury patients, for head injury patients, and so on. But one of the things about spinal injury that I have mentioned is that you do not want to worsen the injury that the patient has sustained primarily. So you found a patient, they have a fracture. It's probably an unstable fracture, but maybe they don't have cord compression, for instance. We do not want, while transferring this patient to the ambulance, for instance, or in the ambulance, or to the next facility, to then, worsen that injury and perhaps result in cord compression, and now have a patient who's paralyzed. But at the same time, there are other considerations for spinal fractures. So we do know this from medicine and ATLS that there's inline stabilization of the spine and nursing the patient in a firm, flat surface. Now, firm, flat surface does not mean hard. Actually, if you look at the current ATLS guidelines, they do not recommend that. They do not recommend the traditional spine boards being used to, laying the patient on that for prolonged periods. Just a firm, flat surface, as many hospital beds are, would suffice. Of course, minimizing any movement that would potentially destabilize a fracture site further. But with regards to what I mentioned in the presentation, acceleration, deceleration forces that do occur in normal vehicles, especially when you have to take off at high speeds or come from very high speeds to slow to a stop, do have an impact on a patient who's lying on your stretcher in the back of the ambulance. And so deceleration would actually, sort of load the spine axially, which means in the line of the spine, you have a load that might sort of push or worsen an injury that's existent. So ideally, the primary message being here that a lot of times, if it's purely spinal injury, as a patient, you can afford to transport slowly and smoothly to hospital without worrying too much about timelines. Of course, if it's a multiply injured patient and you don't have the capabilities, then you need to weigh the risk of transporting them, expeditiously to the facility versus going slowly. Ideally, if you've stabilized your patient at site, then you should be able to, have a smooth and slow ride to hospital, which would be safer for the patient. So there, like many other areas of medicine, there are recommendations, but they're not cast in stone. It's very patient dependent. And it's to just customize the knowledge that you gain from this and other forums, try and give the best care to the patient and the most safe. I hope that answers the question.
Great. That was quite an in-depth answer. Thank you. So the next question that I'll take from Oliver Kavilavu. Is there a mechanism of standardizing ambulances in Kenya, looking at what we have in the market, from pro boxes to matatus being converted to ambulances, where the integrity is questionable? Yeah, that's actually quite true. There are these makeshift ambulances and then they just slap a tag on it. So that's actually quite inappropriate. There are regulations that are supposed to be adhered to. Number one, they actually kept standards on what an appropriate ambulance is, BLS, ACLS ambulances, and what they should all have. That's number one. Number two, even on if you go and check out our website, there are actually guidelines from the government that we've plugged in our resources section about the standardized appropriate ambulances. and different ambulance guides. It's also part of the Kenya emergency medical care policy spanning all the way to 2030. So these are things that have protocols in place already. It's just about actualizing it. But I think on the other hand, as the emergency care providers, we have a role to speak up for our patients in ensuring that when you are transferring a patient and you know it's a critically ill patient, you can't just let them go with any matatu or probox. They should be in an ambulance that can cater to any eventuality along the way and that can actually get them to the other side as important, right? So your ACLS ambulances, especially if it's somebody post-resuscitation and that kind of thing. So considering what your patient has and advocating for your patient so they can actually get to the other side is very important. Okay, let's see. So someone asks, why should one replace the air with saline while flying? I think you mentioned it. Yeah, so like Dr. Evans said, when you're going above, your pressures tend to change. And if there's air in there, it can expand and just rupture as well. So you want to use something like saline where you can actually control it better and it's less liable to those changes in pressure. Okay. So considerations of transferring a patient who has a chest tube by air. Dr. Evans, what do you think?
So, well, there are just a few things to think about when you're transferring a patient with a chest. First, why was the chest fixed? Was it for a hemothorax, for a pneumothorax, or whichever reason? So, number two, should it be for a pneumothorax, or whichever the case? Patency of the chest tube be something that's really key because you don't want to be mid-flight and dealing with an obstructed chest tube in a very constrained space. So you need to ensure that your chest tube is patent and working properly before you leave the ground. Now, sometimes the position of the chest tube is usually also an issue to consider. Now, granted, some patients will have bilateral injuries and might have to fix just bilaterally. But where possible, because of the constrained cabin space, then you want your chest tubes preferably on one side. Of course, this might not always be possible because the patient will be most times against the side of the aircraft and you only have one side to deal with. But essentially, patency of the chest tube, making sure it's working is what's key when you're having a patient that you're transferring. Yeah, I don't know if that's the question that's the answer, or that answers your question. Also, with regards to the question on ambulances, I think there's a blueprint by the government now with regards to emergency care. It's 2020-2025 strategic plan.
Yeah.
And it outlines all the standards that should be adhered to by ambulances. The only question is whether we do adhere to them. I'm sure in here, the audience is probably people who actually run ambulance services. And it's really, it comes down to you actually implementing what's on paper, because what's on paper is really good. Yeah.
Okay, that's true. So now there's a question on a very interesting one. If you lose a patient en route during a transfer, what should you do? Turn back, obtain an OB, go to the nearest morgue. What do we do? Okay, that's a very interesting question. And I'm wondering, have people encountered it before? What have you guys done? Feel free to type in the chat, tell us your stories. But as far as I know, there are no hard, fast protocols on the situation. However, we need to always remember that at the baseline, certification of death has to be by a doctor per our our laws and legislations. So it's really up to you. If the ambulance is just an EMT and a nurse, maybe you can go to the nearest facility, have the doctor assess the patient and the circumstances around what happened, and then maybe they can certify. If the nearest facility is where you've left, then yeah, you can possibly just turn back. But yeah, tell us what if you've encountered such a situation and what you guys did. That would be interesting to know. Another thing, so we've talked about that. So so how do you maintain warmth needed in transport of burns patients in an ambulance? It's a good question.
The maintenance of warmth doesn't really change. It's not too different from what you do on the ground. One of the things you do on the ground is these patients is when you have to warm any patients, not just burns patients, you have to warm them from inside and from the outside, because depending on what temperatures you're dealing with. And from the outside, that includes while addressing the various ways in which a patient loses heat, which is radiation, convection, conduction. So it all starts from having ambient heat. So if you have capabilities to heat a patient with what's equivalent to a bear hug in where you are, then that would help with that, covering the patient up. Okay. But number 3 is when you're giving fluids, not giving cold ice fluids, but warm fluids. Okay. So it really doesn't. It's not fairly different from what you'd ideally do if you're at a hospital as opposed to a transfer. Yeah.
Okay, great. True. I'm just seeing, yeah, people are commenting regarding the death in transit. Yeah, a lot of people say, yeah, you go to the nearest hospital, get certified, then you can proceed to certified or get a BID, brought in dead documentation, and then the cops can get involved and all that. Yeah. Yep. So that's okay. Transport via motorcycles, especially in rural areas. Definitely that does happen a lot. It also depends on what the patient has. If your patient is just something not critically ill, maybe okay. But if it's something quite serious, you still need to get an ambulance, honestly. And that's why also in our casualty apps, it helps you get ambulance numbers based on your county. That's what the emergency medical care plans that AMKF is helping the different counties develop. That's part of it. And there's also a new program and an app called Ambulancy, which helps basically the same in the different counties for you to have access, because counties basically in the public health access, that the ambulance should be part of that. So it also depends on how sick the patient is and where the nearest facility is, and then the getting access to your ambulance numbers per your county. You can also get that on the casualty app. Yep.
I think because of maybe just how much people are not well versed with emergency care, there are all sorts of things happening out there, and sometimes it's not by medics, it's by the public. And you see patients being scooped in all manner of ways and put in all manner of transport vehicles and transferred to the nearest hospitals. And sometimes this is done by cops. And you find people transforming an incomplete spinal injury, for instance, to a complete spinal injury, just by how they handle the patient. So I think the onus is on us, the emergency care providers, to actually just get the information out there on just the basics of how to handle a patient. If they're found, if they're found in an accident, or if they're found seizing and so on. Yeah.
So if you do go to the AMKF website under the our model capacity building, at the bottom right there, we have resources. And some of it we have with regard to ambulance services. There are a couple of, with regard to standards, there are a couple of protocols that you can have a look at, as well as the legislation, the Kenya Emergency Medical Care Strategy, especially 2025, and the emergency care policy all the way up to 2030. Those are good resources to have a look at, especially if you want to advocate more for your patients so that there are better standards of care. Yeah. Okay. Let me see. Okay. Brian asks an interesting question. How do you position a patient with a penetrating or protruding sharp object in the chest and the back, like an arrow or sword? Like, we remember there was the last year, there was the baby who had a penetrating object in their brain, and they were transferred all the way to Kenyatta. That's a good question. So penetrating wounds, one of the things that ideally should be taught in first aid and basic life support is management of penetrating injuries. So ideally, number one, do not pull it out, because you don't know what structures it has gone through to get to where it is. And if you pull it out, it could be the one causing a bit of a tamponade, so that the patient doesn't bleed out. So you shouldn't pull it out. You're supposed to pad around the penetrating object and then secure. So if this is the penetrating object, you pad around it and then secure side to side as well, so that it doesn't move. Yeah. Okay. Simon asks, for transferring patients by stretchers, do you pull from the feet forward or head forward? That's an interesting question. But it's true. Usually your patient ideally should see where they're going. So you want your feet to face forward, their head to be closer to you on the backside. So as if you were the one who was walking, you'd be able to see that. So that's one of the safest ways, especially if you're going down a slope. You should also make sure that you have enough people on that stretcher so that the gravitational force doesn't pull the patient and they fall off. Good. So Joseph Momo asks about procedure of obtaining additional oxygen cylinders. Like we said, before you transport your patient, calculate what your possible need might be, so that before you leave, you actually have enough oxygen, to enable your trip is fully catered for. For the longer trips, you should alert your nearby hospital or stopovers where you can get maybe an additional cylinder, but that's also to the discretion of how your relationship is, county to county, hospital to hospital. Yeah. Then what type of ambulance is recommended for patients who are in remote areas? Again, it's not about the area, it's about what the patient has. So if the patient has something that is more life-threatening, an ACLS certified one where they can actually resuscitate in transit would be more ideal. If it's something less severe, then maybe a BLS would be appropriate. And then also that saying ACLS versus BLS also means in terms of the escorting person, the different cadres that you would need. Yeah. I've seen a nice question here about transport by marine on the waters. Yeah, so that does happen. I know, especially in places like Lamu, there are the boat ambulances. What special considerations are there in marine transportation? That's a very good question. Any contribution, Evans?
So, well, the marine space or the seas not fraught with as many hazards as many other kind of transport modalities. Ideally, in the sea, some of the things that would be of consideration would be, one, there are people who get seasick, and that's not just the patient, but also the crew that's evacuating the patient. But with regards to your capabilities, I don't know of any evacuation ships. I do know that there are people who practice medicine at sea. Ideally, the practice of medicine at sea is similar to the practice of medicine at land, or on land, sorry. With regards to evacuation, I haven't come across people being evacuated by ship or being transported by ship from one critical care facility to another. What I know is that it's possible to manage critical care patients on ship, on a ship in the marine space, um, uh, and offer them the same care or practice medicine the same way you'd practice on land. If you have to transfer them, then the practice has been to transfer them by air where possible, or find the next possible place to dock and actually transfer them onto an ambulance, but not by a ship, because I think most ships, I mean, that would be one of the slower ways to get a patient to where they need to be. So I don't know if the question was with regards to, evacuating patients by water, because I haven't come across much of that, but those would be my thoughts on that.
Yeah, I agree. Yeah, sometimes emergencies can happen anywhere. The people who also, on the larger scale, you can have like the tourist cruise ships as well. Those ones, they tend to, especially in the more developed countries, they tend to make sure they're staffed with at least some emergency care provider in case there's an emergency. And they have protocols on evacuation, and a lot of the time it is air evacuation. So that is true. For the flip side, from main island to mainland, like we said, like in Lamu, sometimes that one can prove a bit of a challenge. I've had some stories about, depending on the time and the tide and how rocky the currents are, it can make it very difficult to get somebody from the island onto the mainland to get to the main hospitals. But again, considerations need to be made regarding what is the most ideal time to set off, number one. Number two, stabilizing your patient prior to transfer, and then preparing to have, like we said, adequate oxygen, any medications you might need in transit, if there's like a cardiac arrest or anything like that. So those are some considerations you'd have to have. Yeah, and then also considering if that mode of transport is the most ideal, because there's a statistics that was given that during the day when the water is a lot more calmer, the transport might be up to like maximum 45 minutes. But if the water is a lot less calm and very the tide is high and very tumultuous, it can even take up to 4 or 5 hours. Some people even sitting even up to 12 hours. So that time you have to really think about, is it feasible to do a whole 12-hour water journey as opposed to, where applicable, asking for air support, or maybe equipping our island facilities a bit better, so things like that. So that's definitely still a work in progress, and it is a challenge. Yeah. Okay. So yeah, some hospitals insist on payment of ambulances before transit. Common in private hospitals, this can delay the golden hour. Do we have free ambulances for those who can't afford? So before, I don't know what our transport system will look like in terms of health, because before they were trying to mitigate this with the NHIF. Like if you're a proper up-to-date paying member of NHIF, then you should still be able to get transport by Red Cross and EPALS. I don't know what that looks like in the transition to the Social Health Insurance Fund. So that's something we need to be looking out for, because it was definitely a huge stride that had been made and had reduced some of the burden of this kind of situation. So to be honest, it does hinder a lot of our care, but also remember that by law, everyone is entitled to emergency care services, right? So again, if somebody is out in the field or out on the road and they need to be transported to the hospital, you can demand for emergency care services and say, I will take you to court because you're contravening the law. But if it is from hospital to hospital, they need to be stable. Yeah, and stabilization continues until the point of transfer. Yeah, okay. So regarding patients on oxygen, can one consider non-rebreather over nasal prongs? Again, administration of oxygen depends on what the patient's needs are. Number one. Number two, if your patient, while you're stabilizing them, tend to continue to deteriorate, ideally, especially to a certain point, like Dr. Evans had said, these are the patients that you'd want to maybe intubate first before you transfer them, and then connect them to your oxygen supply. But again, it just depends on how sick is your patient, how much oxygen do they need, and do they seem like they will keep getting worse, such that the transport time is longer than necessary. So you might want to give them the most advanced way, as opposed to minor or simpler oxygen delivery devices. Okay, great. So in a case of an accident, what is the safest way of transport for mass casualties? So there are mass casualty plans that are in place and protocols. Some are usually, actually all of them should have a MOU or a plan that incorporates your fire brigade, your ambulance services, and the hospital that you want to transfer to. So there's always a plan that is in place. Sometimes maybe people might not know of them, because there's always a strategy in where, and even the incident commander who's in charge of that mass casualty knows, and they establish where the entry point and exit point of the ambulances are, where the triage points are set up, who is going to go into the area and do primary triage of the really sick ones, and the fairly stable ones are taken out to a secondary triage area. So there are mass casualty plans on a larger scale that incorporate all these key players in the industry. Okay, good. So just going to take a few more questions. Our time is ticking. This topic is a very, very big topic. We cannot cover everything in depth in 1 hour session, one hour session. But the most key concept that we must take home from this session is, number one, stabilize your patient where you are at. Okay, make sure that if you plan on transferring them, they have to be stable. They have to be able to reach the other area. Number two, make sure you have all the drugs, including adequate oxygen supply, for them to be able to get to the other area. Number three, communicate with the receiving facility such that they can expect the patient. Remember our SBARs, like what is the actual situation? What do they need for continued care of the patient? Then lots of documentation. In intra-transit, you need to monitor your patients. A lot of the time, I think I've been on the receiving end of a patient is in an ambulance, they're in the back, and then all the escorting healthcare providers are seated at the front with the driver. So let's be pragmatic and let's think about it better, where if your patient needs an ambulance, that means they need to be monitored. So let's keep monitoring our patients as we go along, document the monitoring as well, and then documents regarding what care has happened and investigations that have happened at the transferring facility can make it to the other side as well. Dr. Mbuvi has his hand up. Go ahead. You can unmute.
Thanks so much, Jean. Dr. Evans, that was an excellent presentation. So I just wanted to give some few inputs, maybe for the team for the people who are listening. One of the things is when you're looking at your ambulance services and the ambulances that you have in your counties, in your hospitals, I think one of the things that we need to advocate for is for ambulance drivers to be trained on the emergency vehicle operator course. Most of the times you'll find most of the drivers are just, well, let me just call them regular drivers. And so to some extent, it kind of looks like a whole need for speed kind of thing when they have to transfer a patient. So it's all about how much speed can I get in this vehicle, getting this patient to the particular facility. And I love what Dr. Evans has said, that the ultimate thing first is to ensure that you have completely stabilized your patient so that the journey doesn't have to be a 200 km/h drive and putting everyone else in danger. Personal experience, I have been at the back of an ambulance that has been really cruising, and we had a critically ill patient. And honestly speaking, it's very difficult for you to do anything in a vehicle that is moving at 100, 150 kph per hour. So the aspect of actually having your patient fully stabilized by the time you're actually getting the ambulance coming in and doing the transfer is very key. Number two, one of the challenges that we have faced a lot is where an ambulance just shows up in our A&D and no one called, no one told us, we don't know what the patient has, we have zero clue about the patient. And that time, most of the time, you'll find it's a critically ill patient who will probably end up requiring mechanical ventilation. And these are things that need to be planned. ICU spaces are a very, very limited resource. So for anyone who's transporting a patient, like Dr. Evans had said, ensure that the receiving facility knows you get, as in they know you're coming. They know the status of your patient, the full SBAR protocol, just to let them know exactly what you want to transfer the patient on to refer, so that even on this other side, when they're getting ready, they know how best to prepare for this patient. Because ultimately, at the end of the day, our goal is to save lives. It won't make sense for you to rush a patient to another facility and get there and have the patient still die because the other facility was not prepared. They didn't have the space available. They weren't able to do anything for this particular patient. So those are some of my inputs. There was a question about mass casualties. Like Dr. Jean had said, yes, there are disaster management plans and protocols that are usually in place for most counties. I know for a fact there are trainings for counties that are currently ongoing for mass casualty incidences, for training incident commanders and how to respond. And the one thing about when you're asking about the type of ambulance to use, more so in mass casualty incidents, is that you're looking at what resources do you have. Because you're not going to have the same resources. One county will not have the same resources as another. One hospital will not have the same resources as another. And it's just looking at how best do I utilize the resources that I have to have a greater impact on a maximum number of patients and save the maximum number of lives. So once you have that idea behind, and you have an incident commander who understands the protocols, you know where you are, you know the nearest facilities, and even if the ambulances that you have are either basic life support or advanced life support, there's a certain way you can be able to know which particular patients can I be able to evacuate with this particular ambulance to be able to save their lives. So those are just some of the things that I think could be very good if people actually just, if we looked into them. Yeah, that's my contribution.
Yeah, great. Thank you so much. Thank you for your valuable input. Absolutely. So guys, always remember you're your patient's advocates, right? And let's learn to do the right thing, yeah, so that even when we are in need of the services, we know that the right thing will be done for us. Okay, so I'd like to end the meeting there today. Let's keep reading, learning. Refer to our website as well if you want some more insight in terms of protocols. If you want more insight in terms of where you can get these numbers from, download the Casualty app. You can also just go onto the website as well, get a feel. There's a lot of resources there and a lot of information. So our website is emergencymedicinekenyafoundation.org. Okay, but you can just also Google EMKF and it'll bring it up. Okay, so thank you so much for everybody who has joined tonight. Thank you so much, Dr. Evans, for such an enlightening presentation and sparking such an amazing conversation. Thank you, Dr. Mbuvi, for your contributions. We appreciate you so much. Thank you also to, well, everybody for attending, always being here.